Pleasure to be here tonight, and thank you for joining us. What I'd like to do is just kind of give you an overview of what intraperitoneal hyperthermic chemoperfusion is all about. We call it Hipec, and kind of why we do it and why it makes sense, and a little bit about what patients need to go through to get this treatment, and a little bit about the results that we've had thus far, we and others. So we'll kind of move quickly, and there are a lot of slides here, but I think it'll give you a nice overview, and then we'll have the opportunity to answer questions later. So at the University of Pittsburgh, we do have a regional therapy center that's sponsored by the Cook family, and as part of this center, we perform regional therapy on isolated liver tumors, on peritoneal tumors, on limb tumors, actually on chest cavity tumors, but it's a whole program dedicated to regional therapy and the regional delivery of chemotherapy. Certainly tonight we're going to be focused on the Hipec procedure, the intraperitoneal therapy, which is what we do most of. So peritoneal carcinomatosis is that form of cancer that's seeded through the abdominal cavity. Basically, your abdominal cavity is everything from the diaphragms up high to the pelvis down low, and all of your organs in the abdominal cavity kind of float in a sac, and it's the lining of that sac that we call the peritoneum. And carcinomatosis is tumors that have seeded through the organs and then contaminated this sac or this lining, and you can literally find thousands of small tumors throughout the cavity that just seed like throwing seeds in a garden, and everywhere a cell lies or lands, new tumor forms. And we tend not to see real bulky large tumors, but just numerous small tumors, because as they start to grow, they just shed into new tumors, and that just continues to seed and spread. Here is kind of a list of the different types that we can see, the different types of cancer, from gastric cancer, pancreatic cancer, small bowel cancer, gallbladder cancer, colon, appendiceal, ovarian, breast, mesothelioma, and then pseudomyxoma, which is a low-grade form of appendiceal tumors. And you can see that these we've ranked them in terms of aggressiveness. There are some very aggressive cancers and some that are very slow-growing. And although they don't all fall into this nice, neat order, in general, that's how we see them based on these types. The natural history, it's unfortunately, and especially if those of you that are listening are victims of this process, it's a very difficult process because abdominal pain is very hard to live with, and in general, patients with carcinomatosis will suffer from crampy abdominal pain, anorexia, where you just don't feel like eating, weight loss, and then in advanced stages we can see blockage of the intestine, where food and bowel contents are unable to pass through and things reverse. Ascites, which is the fluid that can build up in the abdominal cavity, different types of infections that result from the patient's weakened state and then succumbing to this form of disease. So it's this natural history that we want to reverse with aggressive treatments for cancers in the peritoneal cavity. And I will say that, as short as maybe 10 years ago, patients with carcinomatosis were often given a death sentence and said, that there really isn't much that can be offered because of this stage of disease was intimidating and the problem significant, and we just didn't have that many treatment options. So there have been a lot of us throughout the country, throughout the world, that have dedicated a significant effort to managing patients with carcinomatosis, and are finding patients live longer and longer, and some patients cured of their disease. And so that will only continue to improve as our treatments improve over time. What is a debulking procedure? This is where we go in surgically and remove anything and everything that looks like tumor. We open the belly through a large midline incision so that we can assess the entire abdominal cavity and literally search every centimeter or every inch of the insides looking for tumor nodules. And we kind of know where these tumor nodules like to land and like to grow. So we pay special attention to those areas, but we look everywhere. And then remove the disease. Whatever it takes to remove the disease, we do it. In general, these tumors do not invade deeply into tissue. They're lying on the surface of the tissue, and we can peel the disease out. But sometimes we have to sacrifice organs to complete the goal, and that's not organs that are essential, obviously, for life, but we may have to take out a piece of the intestine, the spleen, the gallbladder, organs that are not essential in order to accomplish this goal. Certainly our goal is not to do anything that would change the quality of life for a patient, but that has to be weighed against what we're able to accomplish in terms of the potential cure of the disease. We then perform the Hipec procedure after all the cancer has been removed, and this is a directed high-dose intraperitoneal therapy to kill all the microscopic disease that might remain behind. And these are considered very big surgeries, but it's not one that you need to be intimidated by, and it all depends on how much disease there is in terms of how much we have to remove. Some of these operations can go very quickly, within an hour we can be done, and others can take all day, up to 10, 12 hours, just depending on how much disease there is to remove. And this is just an example. This is a CAT scan, and although you all probably don't look at CAT scans every day, I'll point out to you that all this darkened area that I'm outlining here is all tumor mass, and this is a mucinous tumor. So you can see that that this is all disease that's taken over the abdominal cavity in this patient, and what you see here in the white is actually what's left of the intestines. It's kind of pushed to the side, pushed to the back. The kidneys are these small little organs back here, and the rest of the belly is kind of full of this disease. And these are the kind of patients, this is a patient with advanced low-grade mucinous tumor that needs a debulking procedure and a Hipec procedure. Sometimes this disease can be very mucinous, almost a jelly-like material. And that's what you see here, where just a lot of mucin can be removed from the abdominal cavity in these patients. And sometimes it's a more solid tumor, and that's what you see here. This is what we call the omentum, which is a fatty structure that hangs off the stomach like an apron over the abdominal contents. And here we have solid tumor that's invaded the omentum, and certainly a different picture than the kind of jelly-like mucin that we showed before. Yet this is the exact same disease, just different presentations of the same disease. For colon cancer, it tends to be a little more invasive, tends not to be as bulky, and you can see here how it looks kind of lining the tissues here. And as you can see, this can be a little more challenging to get off, especially if it's involving the intestinal surface itself, because it invades and sticks to things. But we're usually successful at removing this disease. And so now to go into the rationale for using the Hipec procedure. Chemotherapy delivered into the peritoneal cavity has a barrier effect, so that we can achieve high concentrations of chemotherapy in the abdominal cavity, but the rest of the body doesn't see the high concentration of chemotherapy. So unlike chemotherapy delivered intravenously, which has to go throughout your body in order to get to the peritoneal cavity where it's doing its job, that is also associated with all the side effects that you're familiar with chemotherapy, in terms of suppression of the bone marrow, making your body, putting the patient's body at increased risk for infection, as well as hair loss and nausea and vomiting and these kind of things. So we're seeing all the side effects, but little or low concentrations of the chemotherapy is actually getting to the tumor. So if we deliver the chemotherapy into the abdominal cavity and literally bathe the tissues, the cells, the cancer in high concentrations of chemotherapy, we can see a good response with those tumors and minimize the side effects of the rest of your body. Hyperthermia is a significant part of this treatment. we know that hyperthermia kills cancer cells directly, but it also potentiates the effect of chemotherapy. So combining chemotherapy and heat together is very effective, and this has been known since the 1960s, when an enormous amount of research went into looking at heat and the heat effect on cancer versus normal cells, and it really is a very functional way to kill cancer cells. The key is the temperature, trying to get it to the appropriate temperature so that we kill cancer cells, but normal cells survive. This is performed at the time of surgery, so it's at the time while the patients are asleep, and that way we avoid any pain or discomfort related to the treatment. We can improve the distribution of the treatment by manually agitating the abdominal cavity while the patient's asleep, so that the mixing is improved. And we do it when there's minimal tumor burden and no scar tissue in the abdomen, so that all areas are exposed. And this is just a schematic showing the abdominal cavity on this side, the tumor nodule here, and then the subperitoneal tissue, and the blood vessels here are quite a ways away from the tumor, and so getting the chemotherapy out of the blood vessels into the tumor can be problematic, whereas bathing the surface is much easier for treatment. Any large tumors like this would be removed prior to treatment, so you're really talking about the microscopic disease that's laying on the surface of this peritoneal cavity that you're trying to address with the hyperthermic approach. This gives you an example of the drugs that have been looked at in the abdominal cavity, and these are a variety of chemotherapy agents that you don't necessarily need to know about. But if you can see, here we show the peak peritoneal cavity to plasma concentration ratio, demonstrating that we can achieve at the least almost a 20-fold increase in concentration, up to a greater than 1,000-fold increase in concentration in the abdominal cavity compared to what is circulating in the bloodstream. And this advantage is significant for treating tumors. As I mentioned, hyperthermia has a selective lethal effect on cancer cells, and if you look at this range between 41 and 43 degrees centigrade, this is where we see a selective lethal effect on cancer cells. At the lower temperatures, we actually see improvement in chemotherapy effects, but it takes the higher temperatures to actually see direct killing from cancer. And then we go above 43 degrees and we start to see damage to normal tissue. So it's very important that we control this temperature carefully. So the candidates for these types of approaches are anybody with disease isolated to the abdominal cavity. In patients where we know and understand that the complications related to their disease, including their life-limiting aspect of their disease, is the abdominal cavity, those are patients that we consider this for. If there are organ metastases like lung metastases or liver metastases or bone metastases, then we're often unsure as to whether solving the problem in the abdominal cavity will gain significant quality of life. And in those patients, we still focus on a more systemic therapy approach that treats the whole body and not just the abdominal cavity. But patients with disease isolated to the abdominal cavity are good candidates for this. In terms of what to expect, certainly here at the University of Pittsburgh, we focus a lot on pain management for patients. We use anesthesia pain team and usually paravertebral anesthetic blocks that help control pain. That's done before surgery. The patients go to the operating room where they are intubated and put to sleep. Lines and monitoring devices are hooked up. And then the patient undergoes the operation. At the end of the operation, we do the heated chemotherapy. And then actually anything we have to put back together, we do after the heated chemotherapy. And then the patients go to the intensive care unit where they stay overnight, and then a hospital stay, which is on average 12 days in our cases. And then after discharge, patients take about 6 weeks to recover from this, again, depending on how much has to be done. and they're quite tired, fatigued. Patients can have some gastrointestinal irregularity and poor appetite, and that's a struggle for that time period when we're going through recovery. But it's generally a steady improvement over time, and at 6 weeks, patients are back to about 90% of their pre-operative status. So it's not horrible, but it is a significant operation, significant recovery. This is just a schematic of how this procedure works. We have catheters that go into the abdominal cavity. We actually use 4 separate inflow catheters that go to all quadrants of the abdominal cavity, and then 2 outflow catheters that drain the perfusate, as we call it, the chemotherapy solution, out. It goes and circulates through a heat exchanger and a pump, and also a reservoir to kind of maintain volume. And it's a continuous circulation at high flow, high pressures, again, to maximize the distribution in the abdominal cavity and to control that temperature. We keep that temperature between 42 and 42.5 degrees in the peritoneal cavity. So we actually measure the temperatures in the peritoneal cavity and hold them right between 42 and 42.5 degrees centigrade, which gives us enough to heat and kill, but not enough to cause significant damage to normal tissues. And there's a variety of ways to do this. This is our old way to do it, which is just to put these catheters through the abdominal cavity after closing the skin temporarily. This is a temporary closure of the skin. But now we kind of go through the incision itself with our catheters and branch our catheters out inside the abdominal cavity. A lot of different technical ways to do this. And I won't dwell on this too much, but I thought some of you may be interested in the published results of different trials. And this is one of the larger randomized trials where basically patients were admitted into the trial, a coin was flipped, so to speak, and patients were randomized either to receive standard therapy, which is intravenous therapy, and palliative surgery, surgery to fix problems, versus the experimental arm, which received the Hipec procedure and a complete debulking procedure. The average survival in patients, and this is colorectal cancer specifically, so it doesn't necessarily apply to all types of cancer, but you can see here about a doubling in average survival from 12.5 months to 22 months in patients receiving this type of aggressive approach. And if you look at these graphs, which are survival graphs, which just show how many patients are still alive over time, you can see how the patients who got the treatment are actually doing very well over time, and the curve kind of straightens out over time, which means patients are cured long-term from this procedure. And this is a very important graph, because what this shows you is that if you have no residual tumor left after the cytoreductive procedure, then these patients did very, very well, and the majority of patients were alive at 3 years. Whereas if there's extensive disease left behind, then patients don't do so well. And that's logical. If you have more disease, you're going to do worse. But it's also logical from the standpoint that the treatment, the Hipec procedure, is really best against microscopic disease. And so our goal from the surgical perspective is to remove all macroscopic or gross disease that you can see or feel, leaving only microscopic disease to be treated. And if we can get all disease out, then patients do better. And that's why often we will recommend patients receive intravenous chemotherapy first, because it can have an effect on these tumors. And if they're tumors that we don't think we can surgically remove up front, then treatment with chemotherapy for a few months may change that and allow us to completely resect the disease. And then if we can completely resect the disease, we expect a very good long-term outcome as shown in those graphs. And this was followed up, this same study, 8 years out. And again, although the curves did drop off a little bit, you can see even out as long as 8 years, patients are still doing well. And the patients that had the complete cytoreduction are the ones that are doing the best. And this is certainly what we're shooting for in patients. Now, again, this is specific for colorectal. Patients with incomplete cytoreductive surgery and some of the appendiceal cancers that we deal with, also do well for a long period of time. We did publish our results from our first 120 patients at the University of Pittsburgh. I think we're up to about 700 patients here at the University of Pittsburgh, and then I had an extensive experience at the NCI before coming to Pittsburgh, so quite a number of these cases under our belt here. But our first 120 cases were published, and we saw all kinds of cancers from appendiceal to colon cancer being the most common, but also ovarian, mesothelioma, sarcomas, stomach cancers, esophageal cancers, some liver cancers, gallbladder cancer, all kinds of tumors in the mix. And this kind of percentage breakdown is still what we see even with our larger series of 600 to 700 now. One important thing that I think is important for patients to know is that the complication rate is high. If you count every fever that can occur in the hospital, everybody that gets sick to their stomach and these kind of things, then about 50% of patients will have something go wrong during the recovery from this surgery. So it's a high risk procedure from that perspective. Now, we had no in-hospital deaths as a result of the procedure, so the mortality rate is very low, and I think that's what the goal should be. Now, with any operation, there's a defined mortality risk because of everything from anesthesia to the heart undergoing stress to blood clots that can occur. So that everything has its risk, but I think we've learned how to minimize the risk for these procedures, which I think is important. And in our results, we did show significant survival benefit for the patients that had the low-grade mucinous tumors, appendiceal cancers, and as well as colon cancers. And these just show similar to graphs to what you've seen before, but prolonged survival that kind of levels out with the hope that these patients are cured long-term of their disease. But some patients will recur later on and can undergo second treatments as appropriate. Now, just a large French study here that was reported recently, just looking at the comparison between the intravenous therapy and the intraperitoneal therapy. And these studies showed that the patients getting the Hypec therapies did much better than the patients that got standard therapy, as did the randomized trial. And we looked at this at the University of Pittsburgh as well, comparing those patients who were getting treated with intravenous chemotherapy for this process alone versus those getting the cytoreductive surgery and Hypec, and again showed that we were doing much better with those getting the cytoreductive surgery. So it's because it's kind of a slowly growing field, a slowly developing field, patients or physicians and oncologists sometimes aren't aware of the treatment or resistant to the treatment. And so these kind of studies, I think, are important and need to be done and continue to be done so that the oncologists and the other physicians treating cancer can understand what this treatment's about and what benefits it may have. And this is just showing one example of a patient just full of tumor that you can see on this plain X-ray 3 months later having a nice result. So in conclusion, high-volume centers with significant experience in treating these diseases can have a very good mortality rate and can have very good outcomes for this type of procedure. Overall, the Hypec procedure results in a major improvement in overall survival, certainly in the randomized studies as well as the historical controlled studies that I showed you. And we think the most important factors in successful outcome, patient selection is certainly important, making sure that they have the appropriate tumor burden to treat, the completeness of resection, so how well we do on the surgical side, the experience of the center, and then the combination of treatments where we may combine the intraperitoneal therapy with intravenous therapy to maximize response and try to push towards that cure for this horrible disease. So I will stop there, and we'll